My talk here has two titles because I couldn't decide which one to use. And I started with epidemiology today, so that's the one you have in your printed program. But if you go to the online program, you'll find a second title, which is the causes of epidemiology. And I'm going to try to speak a little bit of each one of those. I'm going to start with a short story about a Brazilian scientist, Mauricio Rocha e Silva, who died in '83. He was a brilliant scientist. He was a pharmacologist, not an epidemiologist, but nobody's perfect. And he was asked once in a conference, do you have an international conference? Like in Brazil, nobody would ever ask him that. But he was asked in a conference outside Brazil, do you have statistics on snake bite in Brazil? Because he used to work developing sera to treat patients who had been bitten by snakes. And he said the following. He said, nobody knows. Where we have snakes, we don't have statistics. And where we have statistics, we don't have any snakes. So I think that's a great story. And it reflects a lot about what we have in the world today in terms of epidemiology, in terms of vital statistics. And I'm going to try to build up my talk around this story. And in Brazil, as you can see from the slide, we have a south-north divide, not a north-south divide, in which the south has all the statistics and all the money, and the north gets the snakes. Now, I'm going to talk briefly about Jon Snows' contribution, and then I'm going to take stock of who we are today, who are epidemiologists today, what we do. But I'm mainly addressing the issue of what we should be doing and what is the role for epidemiology in tomorrow's world. So let me start with Jon Snows' contribution. I don't know nearly as much about Jon Snow as many of you in the audience, and certainly not as much as Nigel, who preceded me this morning. But when I look at the forefathers of epidemiology and you know, what is Snow's role and what caused epidemiology to be what it is today, you can see that there were many other scientists who made scientific contributions and methodological contributions that was at least as important as Snow's. You can talk of Farr, we can talk of Grant, and so many others. But if you Google who is the most famous one, that's what you get. You get 31,000 hits for John Grant, 121,000 for Farr, and 1.4 million from Snow. So he may not have been the greatest contributor to the birth of epidemiology, but by far he's certainly the best known. So that tells us something. Why is this the case? I think it's because he combined sound, basic epidemiology, user-friendly presentations of results. His map is great. You know, anyone can understand his maps. Even the natural experiment of the two water companies is also very nicely presented, very clearly presented. And he was really able to convey these results to a broader audience. So when we talk about mode of communication, which we heard about this morning, we can also talk about how communicate our epidemiological findings to lay audiences and to policymakers. And it's actually an art. It takes a lot of effort, and I think Snow was a natural in this term. He really managed to communicate it very well. And the third point that I would like to address, and I just want to add a little, open a little bracket here. I think we epidemiologists sometimes are very boring people, you know. We take a lovely story, such as the one of the pump, and then we say, oh, but the epidemic was going down anyway. People had moved out of London. So I actually like the previous version better. You know, it may not be true, but it had much more appeal. But it reveals something that Snow was good at doing. He was good at communicating and translating science or evidence into action. In this case, it took a while to get the action done, and the epidemic was almost finished by the time the action was taken. But it is very important that we do not only publish our papers, but we also try to get it transformed into policy. A really important thing. And Snow didn't have the excuse here of having to wait for reviewers and re-reviewers and whatnot. At that time, there was no system that would delay him that much. But actually, by the time he got his action going, it was possibly too late for the epidemic. But that's why he has 1.5 million hits in Google and the other ones don't, because he really managed to convey his results and to be interpretable in a way that could lead to public health action. Now, this is one of my favorite books of all time, and it was up on the screen this morning, Jerry Morris's Uses of Epidemiology. And I want to use this book to reflect on what we do today and what we fail to do. And if you look at the 7 uses of epidemiology, 7 is always a nice number to have. 7 sins or 7 uses. It's a nice number that catches people's attention. And what Jerry did was he said, well, look at what can we do? What can epidemiology do? How can we be useful? Well, we can study the historical trends and make projections. We don't do much of this these days. We may study trends, but the economists do all the projections right there, even the projections of the diseases. We can do community diagnosis. We can evaluate health services. We can estimate individuals' chances and risk. And then there are 2 that we don't do that much these days, but Jerry thought it was an important pair of uses. Completing clinical pictures and identifying syndromes. And then we get to the 7th, which is what many of us spend most of our time doing, which is searching for causes. What I would like to argue here today is that I think the first 3 are extremely important, and we really should be paying more attention to these. And if we look in the global picture, these are certainly some uses of epidemiology that we as a discipline have been overlooking. And I'm not trying to question the presenter who's following me here today, but Ken, I think in a way epidemiologists have been kind of obsessed with causation. And not that we don't do it very well or that we can't improve it, but somehow it has taken such a huge amount of our efforts that we are overlooking some of the other things that we should be involved in and may have a bigger impact on global health in a short term. So it's not an either-or position. I'm just trying to be a little bit controversial here and say, yes, we want to search for causes, but we also have other things that we can do probably better than any other discipline. So let's see who are we today. And obviously, as in any epidemiological investigation, we have to decide what is the case definition. So who is an epidemiologist? And that is more complicated than you may seem. We tried to do that in a series of articles that are coming out in IAEA. Started coming out a couple of years ago, and they are about the challenges and the numbers of epidemiologists and the health status in different parts of the world. And we're doing one region by region. We still have 2 papers to come out, which we hope will come out in the next year or so. But we're trying to take stock of what's happening over the world. Now, let me take a quick poll of the audience here. I think there are 3 types of epidemiologists, roughly speaking. There are people who are researchers and teachers in academia. There are public health professionals who whose job description is to do specific epidemiological tasks, such as cancer registries or disease surveillance, outbreak investigation, vital statistics. And then we have multifunction public health practitioners who use epidemiological skills, but this is not their basic attribution. So can I take a quick poll here and say, if you're in number 1, if you're a researcher or teacher, please raise your hand.
Do we have to pick one?
No, you can do more than 1. You can raise both hands. So I get a vast majority here. Who's in number 2? Okay, so we have maybe 20 hands up. And who's in number 3? Oh, quite a few. Oh, that's very good to know. I'm asking you that because when I travel to different epidemiologic conferences in the world, there are some things that strike me. And one of them is this. This is a Brazilian Epi Congress. There's an overflow room in which a couple thousand more people were sitting. We have at least 5,000 people in each Epi conference in Brazil because the vast majority of people here are in number 3. And epidemiology is considered an exciting subject in Brazil, and a lot of people want to come and attend and learn. And so we have a very interesting difference here. I think if I saw the show of hands today, number 2 here is the category that had the fewest people, and number 3 had a few more, but nowhere near number 1. But if you go to epidemiological conferences in other parts of the world, you may find that the vast majority of people are not academic epidemiologists, but they're people who use some epidemiology as part of their work. So there's an interesting variability here, and we're talking about people, we're talking about places, and we're talking about time, and the people who are epidemiologists, places, are they the same in Brazil and in the UK? And I think they're not. And then we're going to talk a little bit more about time, about what we should be doing in the future. You have seen many of these maps. This is a politically correct map, I think. It shows that Brazil is greater than Greenland, as opposed to all the maps which are drawn from people originally living in the northern hemisphere, where Britain is almost the size of Argentina, which is, I can tell you, it's not short, even without the Malvinas. So this map shows the distribution in the world of geographic area. This is the population. You see Asia is highly inflated. Africa is very big. But this is first authors of epidemiology papers. Look at the size of England. Okay, US. And now you say, okay, no, but the IAEA is better than that. The IAEA, we have a global outlook, and we can get people from low and middle income countries. Not really. This is where the IAEA members are. So I think one of the greatest challenges that we have is that we have the vast majority of epidemiologists doing research on diseases and conditions that are prevalent in their own countries, which leads to this 10-90 gap. I don't know how accurate the figures behind this 10-90 gap are. They're probably not very accurate. But the idea is that 10% of the global investment in health research is directed at 90% of the global burden of disease. I think it's a little better now than it was done when this was done about 10 years ago, but it's still largely true. And if we look at the previous map here, in which we say, where are the epidemiology publications, we will see that only 2% of those are from African authors as the first author. And yet, if you look at the distribution of deaths by region, you see that about 1/4 of all deaths in the world take place in Africa, half in Asia, and all the rest take place in the other regions. So there's a great imbalance here. The places with high mortality, high global burden, high burden of disease are the ones where there are fewer epidemiologists. And for this reason, and you may recognize the white guy in this picture here, this is Neil Pierce, my previous president of the IAEA. So we're really trying to invest hard in the IAEA. We found that we do not have enough critical mass to have an epidemiological association in each region, in each country, but if we have a federation, we can actually get enough epidemiologists together to get moving. Now, let's go to the second part of my presentation, or the third part, in which I'm trying to look at what are the causes that we should be supporting. How should we be involved in the new agenda that is taking shape after 2015? And why do I say 2015? Because we are, the international global agenda on health and development has been very heavily influenced by the MDGs, or Millennium Development Goals, which are 8 goals. And they were set in 2000 by politicians, basically, UN diplomats, country leaders from 192 countries. They were endorsed. But it's very interesting that epidemiologists had virtually nothing to do with setting these goals, and even less to do with measuring them. Starting with the fact that the goals were set in 2000 with the baseline of 1990. And I've never seen that before in my life. You know, you establish 24-year goals when 10 years have already passed. And then we try to hold countries accountable for progress. You know, they didn't know. I didn't know. You know, I didn't even know there would be a goal on this. So, and the MDGs have 3 goals related to health, specifically related to health. MDG 4, which is on child mortality. under 5 mortality, MDG5, which is maternal mortality, and MDG6, which is HIV, AIDS, and other infectious diseases. Now, the thing is, if you have goals, you have to measure them, and you have to monitor progress. And this is one thing that we have been involved in, and the IAEA has been involved in, which is the countdown to 2015, in which we have specifically addressed the goals related to maternal and child health. In this initiative, we try to track progress mainly on the coverage of life-saving interventions, who is getting it, what is the population coverage. But the main point here is that we have to focus on accountability. It's a key word. We're trying to make not only countries accountable for progress or lack of progress, but also international donors, the governments from high-income countries, UN agencies and foundations to actually get their act together to move towards these goals. The IAEA is one of the partners in this. Here's the London School, too. Here's my own university in Pelotas. So it's a multi-stakeholder initiative in which we try to, every 2 years, publish a report saying how far are we moving. And this is what our report looks like. The core of the report are 2-page country profiles. And they are highly tested with people from the communication side to make sure that information is user-friendly. And we show them to policymakers and decision makers at country level. They come back to us and say, I don't understand this graph. Can you show it in a different way? So there's a constant effort of improving the graphs. But what I really wanted to highlight to you here is that you take a country, for example, like Angola, and you will see that it looks like there's a lot of data, but actually there's not that much data. There are huge data gaps. A lot of the information is modeled. We really don't know what the maternal mortality ratio in Angola is, so we model that. We don't know what the causes of death are, so we model that. In many of them, we only have one data point, so we don't know if it's going up or down. So the problem of the snakes and the statistics, where the mortality is highest, that's where we have the fewer data to present. So what can we learn from the MDGs? I think the MDGs had major important achievements. They really focused, selected a few areas for action. Everybody knows about the MDGs. You go to school children in Brazil will be able to tell you what the MDGs are. It really led to a massive advocacy effort. And it improved aid. There was more financial aid to low and middle income countries as a result of the MDGs. But obviously there are some shortcomings. There are shortcomings related to how they were conceptualized, how they were executed, who owns them, is that the UN or the rich countries or the low and middle income countries, and the issue of equity. That was completely overlooked in the MDGs. MDGs are national goals. It doesn't matter if some people still have huge mortality rates. As long as the country is doing well, that's fine. So these are how do we act upon this? Well, if we go to conceptualization, there are some key areas that were left out. Climate change was not mentioned, although by 2000 there was plenty of evidence that was taking place. There's some indicators that are difficult or impossible to measure, and some targets are unrealistic. Most countries are not going to reach the MDGs 4, 5, or 6 for health. That's well known by now. We only have 1,000 days to go until the end of the MDGs, and most countries are not going to meet them. So some of the targets are proving to be very hard to reach. The good thing about the MDGs is that we now have more data. These are countries with surveys than we ever had before. We still don't have enough, but there has been an increase in data collection. But some of the key indicators, such as maternal mortality, they are completely modeled. I think the only country I know that has actual data on maternal mortality from low and middle income countries is Bangladesh, because they have these huge surveys. No other country has. So what do we get? We get a model. We put in GDP per capita. We put in fertility rate and skilled birth attendance. And we say the maternal mortality from Angola must be 270, because that's what the data is suggesting. So it's very hard to hold a country accountable on a modeled prediction, because we really don't know how many deaths there have been. So when we move on to the post-2015 agenda, we will see now that there's a whole lot of action and multiple websites, multiple documents saying what should we be doing after 2015. And keywords that we are hearing relate to development, to climate change, rightfully so, to human rights, to social determinants, to equity, universality of access to care, and integration of health and development. However, the real challenge is how to take these high-flying words and transform them into focused, manageable indicators, realistic targets, and timelines. And I think this is an area in which we epidemiologists can make a real contribution. There's a real discussion whether or not we will have a post-2015 health goals. Some people say we are not going to have a health goal. They're all broader issues related to development and to sustainability. So we have to argue and to advocate for a health goal. And I actually think we should stop fighting among ourselves. You know, there are great omissions in the MDGs. Communicable diseases are not there. Mental health is not there. Injuries are not there. But there's been lots of different parties in the health field that are arguing we need an NCD goal or we need a mental health goal or whatnot. And I think we really should be thinking bigger than that because we risk not having a single health goal. And obviously there's the emphasis on equity and on integration across programs. We are trying to play a more active role. We are trying to push for a goal that includes NCDs as well. You know, I'm a maternal and child health person, but the IAEA as a whole, there's a very strong perception that we need to have a greater global attention to NCDs. And we produced this document in which we posted in this debate, in which we say, why not use life expectancy as an overarching health goal? Because life expectancy is driven by different diseases in different countries, an increase in life expectancy. But there's a great need to invest in measurement, of course. I'm coming back to this issue. There was a big debate because the WHO went and said, we want universal health coverage with health services as the goal. And we think it's too narrow. You know, we epidemiologists, or at least we in the IAEA, think medical care is one aspect of health. I know it's a great goal. Universal coverage is a fantastic goal. But there's more than health care. There's more than medical care. And we have to look at the broader social, environmental, and cultural determinants of health. So we think we should go broader than that. And actually, The Lancet picked up our comment and said, you know, how long people live for is an easily understood concept which accounts for the multiple determinants of life and disease, in opposition to the original WHO position. Now, let's take a break now and tell you what is happening now. This meeting took place last week. It's called a high-level panel of eminent persons. Nobody from the IAEA was included, invited, you know. But it's quite interesting because you go to their final document with about 3 pages and you look for health. The only mention they make of health is healthy trees. So we go back to this issue that Paul raised this morning, you know, with the vegetable kingdom, epidemiology for the vegetable kingdom. And I was thinking if Jeffrey Rose was still with us, he would probably write a paper on healthy trees and healthy forests. But the interesting thing here is they have a whole paragraph on data, which you would not expect from the traditional eminent people to worry about, but they actually had a whole paragraph on data availability, the need for investment. So that's very good news for us. Even though they don't mention health per se, they do mention the need for better measurement. So I'm now coming to the end, and I just wanted to reflect with you, what are the role that we should be playing here? I think we have to advocate. You know, why is this important? This is really important because this is what will drive global investment in the next 15 to 20 years. You know, there's no question that these goals drive investment in research, investment in health programs. So we have to pay close attention to this. We have to advocate for a core set of valid and reliable information indicators. we think life expectancy should be at the center. It's not an easy thing to measure. We measure child mortality pretty well, but we don't measure adult mortality well. So this is something we should be investing in larger, bigger surveys in which we can actually get information adult causes of death in countries where the vital registration system is weak, at the same time that we help these countries build up their vital registration, which is the ultimate source of good, sound data on mortality levels and causes. We have to help design, analyze, and conduct these surveys to obtain baseline data, which we did not have for the MDGs, so we have to act right now to get baseline by 2015 and build capacity where it's needed. We have to go out of our academic enclave, and we have to move out to the broader community, because we have to work with multiple partners to develop accountability mechanisms similar to the countdown, translate monitoring to non-technical audiences, evaluating the impact of interventions, balancing advocacy with evidence, easier said than done, because if we wait for the final rigorous response to every scientific question, it may take us very long to act. And some of us may think that did Snow act too fast? Well, maybe he did. But he was right. And we have to focus on action. That's why we go back to Snow. Sound basic epidemiology, user-friendly presentation of results, evidence-based action. So I want to conclude by saying that we're going to have a long day today. So I think many of us will walk down to the Jon Snows pub by the pump and have a drink at the end of the day. And last night I was looking up for a way to finish this talk, and I have to confess to Nigel that I didn't have his book at hand, so I looked at Wikipedia. Should never confess that in a talk, but I looked at Wikipedia, and this is what I found. What would Snow say about having a drink at the end of the day? Well, in the 1830s, he became a member of the temperance movement. He lived as a vegetarian and teetotaler. So that's bad news for those of us going to the pub. But then, upon medical advice, as his health deteriorated, he went back to drinking and eating red meat. Obviously, he died about 5 years later of apoplexy. Thank you very much.